It's a great pleasure for me to be able to present an update from the new World Health Organization Classification of Tumors 5th edition, and specifically as it relates to the head and neck. Unfortunately, I do have some disclosures from several royalties, and also in this particular case, being a standing editorial board member of the World Health Organization Tumor Classification, as well as an expert member for this particular edition. If you don't know what the names of things are, then the knowledge of them is lost too. This was a quote from one of the original books by Carl Linnaeus, as he was coming up with a classification system for botany. And so if you look at that, where we are today, giving the correct names to cancers, that we are ready to make a mission to defeat them. So with that in mind, let's talk about the strategy first of all. So since 1956, the World Health Organization has been responsible for the classification of tumors in all organs and systems. And specifically, the Blue Books provide an evidence-based classification for tumor types to enable diagnosis and research worldwide. Of course, this underpins patient treatment as well as research into all aspects of cancer, both causation, prevention, therapy, and even education. So the WHO books are not just for pathologists. They offer a whole variety of different groups of people that are involved in cancer and tumor classification. There have been several updates and things that are different now with the 5th edition, specifically around governance, quality and standards, and of course, production. So let's just talk about the better overall governance. First of all, the editorial board was established in 2017 with both standing members as well as expert members who would lead the classification and decide on what the entries and so forth would be based on evidence. Informed bibliometrics were used to select the various editors and authors, removing selection bias from this process. And in fact, there have been more than 2,500 authors involved in the overall 5th edition. There have been several other organizations involved in the classification system as well, from coding and staging to genetics and implementation, among several others. So when it comes to the quality and standards, there has never been one specific overarching classification managed in a database using Linnaean principles. And so that is what has been performed with the 5th edition, greatly improving harmonization across all of the various anatomic sites. So for instance, things like neuroendocrine neoplasms have been uniformly addressed throughout all of the body systems. Same thing with hematolymphoid, soft tissue, and even familial syndromes, metastatic disease, melanoma, etc. So it allows for the same terminology and the same diagnostic criteria to be utilized no matter what it may be. There has also been a significant improvement in the image quality, linking the references to PubMed unique IDs, standardizing the various approaches with statistics, and of course, covering global epidemiology as well as mandating SI units, specifically as it relates to mitoses with per 2 square millimeters. There has also been a major focus on multidisciplinary approach. So much of what we do in daily practice involves the working with multiple different groups in order to get the best management for the patient. And so those same individuals were used to come up with the classification system. Now, you may say, what about the production side? Well, they are now going to be on a every 5-year publication basis from the time that the first volume appeared. And this is going to greatly speed up the process versus what it may have been in past, where there were up to 12, even 15 years between the various editions. Furthermore, website access is going to allow for easier access to references and digitized whole slide images, and of course, notes that would be able to be made by individuals in that setting as well. So overall, I think that there has been a great improvement in just the underlying mechanistic approach to what we do with the World Health Organization books. So as you know, it's managed by the WHO Tumor Editorial Board. This is chaired by an individual from the IROC system with multiple standing members. Those standing members are nominated by various societies, specifically around cancer diagnostics globally. They serve for a 3-year term, which may be subject to 1 renewal, but absolutely no more than that. So a 6-year term limit, if you will. The expert members have been selected also based on bibliometric knowledge of the field, using consultation as well as input from those standing members previously described. They serve on the board for the duration of the book in which they're appointed. They can serve on no more than 2 books simultaneously and also no more than 2 editions. So the idea behind this is to allow multiple different individuals over time to be able to be involved in the tumor classification system. Of course, all of the members have equal status, so everyone can say exactly what they feel. And even though Zoom allowed for an instantaneous muting if they became a rowdy group, it still allowed for everyone to have an equal standing in these meetings. So the authors were selected the same way, using these bibliometric searches and having a substantive publication in the field during the previous 5 years, taking various geography and expertise into consideration, and of course having English as a written language for submission as the first or responsible author role. There were lots of different people involved in this as well. While pathology certainly is perhaps overrepresented, individuals from cytology, oncology, surgery, radiology, etc., were all included in order to be able to have a much more multidisciplinary approach to this. So specifically for the entire 5th edition, there are 31 standing members. So this tells you that it's a very broad group of individuals, 14 countries and all the disciplines represented, with almost 200 expert editors for each of the various sub-books or anatomic site distribution. More than 2,500 authors from 30 countries are represented in this. So now let me just narrow it to the collaborations. I think this is a very significant thing as well, with the collaborations working with a variety of other international organizations. So let's just take ICD-9 and ICD-10, ICD-0 specifically as the groupings. These are, as you know, utilized globally for standardization of topography and morphology, as well as behavior taken into consideration. There has also been working with the UICC and HACC for staging, while the International Collaboration on Cancer Reporting, or ICCR, has been involved in the standard general reporting of these lesions. And then, of course, multiple different academies and organizations or societies from the global community are used for implementation and recommendations on what is going on with the work. So here is just an example of such a thing. This is taken from the salivary glands as a histopathology reporting guide from the ICCR, and these are freely available from their website and allow for everyone across the globe to utilize the exact same information in their reporting system so that there can be a comparison meaningfully between not only different organizations, but also different geographic areas. So of course, the ultimate goal for all of this is to be able to improve patient care, cancer prevention, and producing a definitive evidence-based classification of all tumor types that will enable diagnosis and research worldwide. So as you know, with these various books, 6 have already come out. There are 3 presently in beta version on the World Health Organization Tumor Online System. If you go to tumorclassification.iarc.who.int, you'd be able to see this entire group. And here is an example of them now. You will notice that the head and neck one here at the top is the most recent addition to this, with a little small beta written there, as this is still a work in progress. Part of this is just to say that if one does go there and there's a typographical error or a syntax error, or heaven forbid, an error of omission or commission, they are still able to be corrected prior to the print version of the book being released. So if you think back to how the overall meetings have gone in the past, this was an example of all of the members of the 2003 or 3rd edition classification in Lyon, France back in July. This is the one that occurred in January of 2016. As you will tell, we're indoors because this is, of course, January, and who wants to be outdoors in Lyon in January? And alas, this last year, 2021, Zoom took over the IROC system as well, and so the WHO editorial board meetings were held in this particular disposition. Nonetheless, we were quite successful in what we were able to do, and as you can see, 19 different expert editorial members were there. In comparison, there were only 5 for the 4th edition, so you can tell how there is a greatly expanded and increased number of expert editorial board members. Specifically, each one was responsible for at least one major anatomic site, or perhaps multiple different anatomic sites, and then, of course, input from various other individuals from cytology, radiology were also incorporated in this editorial board. You will notice that there are some asterisks. Those 4 individuals, in fact, are standing board members who happen to have an interest and expertise within this area of head and neck, and or specifically as it related to the hematolymphoid, neuroendocrine, and or soft tissue component. So 251 unique diagnostic entities were included. Specifically, subtypes that had formerly been called variants were included under an entity. about 280 different authors with 30 different countries represented, and of course a hierarchical classification was implemented. So what that means is that you actually start off with things like the hamartomas and reactive or tumor-like presentations, to those that are benign tumors, the uncertain or borderline tumors, and then finally the malignant tumors, with an assessment to try and calculate the overall malignancy or grade. So going from those that are the more benign category or low grade potential within the malignant category all the way up to the highest grade. So this is a much more logical presentation than the previous one, where it started off with malignant tumors and may have been just related specifically to frequency rather than to biologic behavior. Lots of different instructions were given. I am not going to go over this in excruciating detail, but just so that you know that everyone did actually have the exact same instructions on what it is they were supposed to do, how they were supposed to build the images, whether they were going to create composites or not, how to give guides, no letters and symbols. I mean, it was very, very specific and included a lot of different things for us to do. But as you can tell from the ultimate book, you can see that there are multiple different images. I'm showing just two of them on the far left-hand side, and then you can see the composite guide that the author had submitted below in order to be able to give a better understanding of what may be able to be included. So needless to say, a very comprehensive overall approach to what happened. So let's talk about the book. And in this particular instance, I'm actually going to build a chapter. So the point behind this is not to be annoying, but just to show you how very easy it is for the authors to have gone into the system and to be able to create each of these diagnostic entities. So you will notice I'm doing ear squamous papilloma for this particular diagnosis, and you will see how we are going very rapidly through the various categories that are available that are very heavily standardized throughout. So definitions and related terminology, subtypes, things like localization and talking exactly about where it occurs and why it is significant, including things about imaging. Clinical features are one of the other topics that are discussed, where you talk about what the incidence of the lesion is, what other symptoms may be present for the patient. The epidemiology for each of these lesions revolved around incidence and frequency, as well as whether it was in males or females, and sometimes related to age and demographic related information around race. The overall etiology, sometimes there isn't much, as you can see here that it's only an HPV-associated lesion, but still whatever etiologic factors may be included were incorporated. Pathogenesis allows for information specifically as it relates to potential for genetic pathways or otherwise tumor-associated findings that may be leading to the cause of the disease. The macroscopic appearance we all are very familiar with and allows for a brief understanding of what those particular findings may be. The histology, of course, includes standard H&E related material. If there is anything specific around immunohistochemistry or perhaps about grading, that would also have been incorporated in that area, along with a differential diagnosis. Cytology and some of these factors were very significant within salivary gland and neck-related lesions. Of course, here for a squamous papilloma, it was not really clinically meaningful in that sense. And then, of course, things like the molecular testing, if it is required for diagnosis, that would have been included. Staging and essential diagnostic criteria. This is a new category where you have the exact thing that needs to be present in order to make the diagnosis, and allows for a very quick snapshot of what those particular features may be in order to come up with an accurate diagnosis. And then finally, things around staging and predictive value. Treatment is not given, but rather the information around treatment may be included in order to be able to give an accurate assessment. And so here you can see, in the time that I have spent for just a few moments, you can see that the entire chapter has been built, and that is what happened with the book. So the major changes for this edition specifically are related to aggregating things from all anatomic sites into their own chapters to avoid redundancy. Specifically, this related to salivary gland tumors not being repeated in each anatomic site. The same thing with soft tissue hematolymphoid and melanocytic lesions. They were all incorporated into their own entity chapters so that there is not repetition except for some site-specific exclusions. Metastases to the head and neck were also included as a single overarching chapter, just like germ cell tumors. And then The neuroendocrine tumors and paraganglioma were specifically incorporated into their own chapters, which I'm going to talk about a little bit later on. And finally, the genetic tumor syndromes in which there is a major head and neck manifestation were presented here with 15 different entities described. So what are the best features forever? Well, I know BFF is supposed to stand for something else in common parlance, but nonetheless, I think it's a good opportunity to say that the books are going to be hosted in an interactive format online. This is optimized for both desktop and mobile device, so you can have on-demand, anywhere access for this. The online version, of course, will have much more images than the printed book because there were several more images submitted than can fit in a printed book. The virtual whole slide, I think, is probably one of the most significant things to include in this edition as well, where there is a whole slide for each of the diagnostic categories. As you know, the references link out to PubMed numbers. The essential and desirable diagnostic criteria for each entity allows for a very quick review of what those will be. And then finally, radiologists and cytologists were included so that those particular parameters, especially as it relates to the head and neck, were now going to be incorporated. So let me just drive what it looks like to be on the World Health Organization classification site. You just go to tumorclassification.iarc.hu, and here you would be able to see these. So let's look at the head and neck. Here is an example of each of the various chapters. I'm just going to highlight that the entire book, as I just described, is going to be there. And specifically, let's just go and look at how the layout is. I'm going to choose the head and neck area for neck specifically. Let's just talk about branchioma as an example so that you'll be able to see how it's laid out online. So all of the various categories that I've already spoken about and the specific entity groupings have been listed on the far left-hand side that allow you to be able to see what those features are within the context of the text itself. As you look through the text, you can see that there are many linked references. So the linked references, in fact, are very, very helpful for this because it allows you to be able to go and click on one of those and automatically go through to PubMed. So here is an example. Why don't I just click on this and you'll see we can launch into the PubMed website. Here is an article on the nomenclature with a link through directly to the overall PDF, where now you could actually click on it, download it, open it, and now you would be able to read through the exact source material that was utilized as part of that particular reference in the book so that you're actually able to read it easily and get a feel for what is going on. So I think that's fantastic. Now, the images, you can look at them in a small fashion, or you can actually open them in a much larger appearance, as you can see here, that allows for a very nice opportunity to review several of the images. They are all standardized to be exactly the same overall size, with the number of pixels being identified to be standardized throughout. However, I think one of the best features and one of the best characteristics for this book is this feature, the whole slide image. So this allows you to actually go and look at a whole slide of what the person who wrote that particular chapter feels is the best example of this entity. So here you can see, as I drive very quickly, you can go up to 40x magnification and see the histologic features as they've been described in the chapter and look at them yourself. In fact, you're even able to capture some screenshot captures of these images in order to be able to get to the same diagnostic conclusion. So my view of this is that it's an incredibly fantastic opportunity to be able to look at the book and see everything online in a really interactive fashion. As I've already suggested, the International Collaboration for Cancer Reporting has been utilized for this book as well, allowing for the various entity categories to be specifically filled in. The data sets and reporting have been standardized with explanations and recommendations for the guidelines included in various articles that have already been published. So I think this is a great opportunity to be able to look at these histopathology reporting guides that allow for standardization across the nation. So let me just talk about a couple of the categories in this introductory lecture, just so you'll see what we did, and then we'll go into them in more detail with the other presentations. So tumor-like lesions of the neck were not actually included in the 2005, 9 in the 2017, and 8 diagnoses were included in the 5th edition now. Lymphoepithelial cyst and branchioma were included as new entities in this location, and Merkel cell was moved to the neuroendocrine tumor section. So as you know, lymphoepithelial cyst is a descriptive term for a benign acquired epithelial line cystic lesion associated with a dense lymphoid stroma. Of course, we all are very familiar with this in the parotid gland, lateral neck, or even floor of the mouth. So there is nothing really profound, just that it has been now incorporated as one of the reactive but tumor-like presentations of an entity. Branchioma. This used to go under the name of ectopic hamartomatous thymoma, but since it is not ectopic, it is not hamartomatous, and there's no thymoma documentation within it, the name didn't really quite make a lot of sense. So branchioma has now been incorporated as the diagnosis for this entity. Usually solitary, well circumscribed lower anterior neck, haphazard proliferation of spindled cells, epithelial islands, and adipocytes without any primitive elements, as that would move it into an example of a teratomatous type lesion. Little squamoid islands and anastomosing nests are also seen with these very nice plump spindle cells. Sometimes myoid features and even fat cells can be seen within it. And of course, in isolated cases, malignancy or carcinoma can be identified. So an example of the imaging on the left-hand side with a very nice example of the low power for a branchioma on the right-hand side. Here you can see a haphazard admixture with a very prominent spindle cell area on the right, much more of a cystic appearance with the epithelial lined spaces, squamous epithelial islands and adipocytes easily interspersed with one another. And of course, the spindle tumor cells can be seen throughout, staining positively with smooth muscle actin in several of them. So that is the only new entity for that particular category. I'm going to now discuss the neuroendocrine neoplasms and paraganglioma, because this is a very new incorporation and a standardization across the entire book. And so I think this is one of the most significant changes in the book. So neuroendocrine tumor is going to encompass grades 1, 2, and 3. They are site-specific, although in many anatomic sites, the full definitions of each of the grades has not yet been defined. And then, of course, as you know, neuroendocrine carcinoma, encompassing small cell neuroendocrine carcinoma, large cell neuroendocrine carcinoma, and Merkel cell carcinoma at this time. So if you think about neuroendocrine tumor as an overall group, these are well-differentiated epithelial and neuroendocrine neoplasms that arise in the upper aerodigestive tract and salivary glands, arising from the dispersed neuroendocrine system. And of course, imaging studies, specifically around 68 dodecate, can be quite helpful because they target the somatostatin receptors that are found within the tumor cells. And so can be quite useful in localization and staging of these lesions. So here you can tell such an example, two different images, one showing that there is a neuroendocrine tumor in the neck, immediately adjacent to the larynx. And then you can see that there is multifocal disease as represented by a lesion occurring elsewhere in the upper aerodigestive tract adjacent to the trachea. Now, of course, metastatic disease can also be seen, and that is what is noted on the right side, where you can see multiple areas of bone and lymph node metastasis from a lesion. So it's a very, very powerful tool that can be utilized at this particular time. So if you talk about neuroendocrine tumor now, rather than neuroendocrine neoplasm, which is the overarching category, neuroendocrine tumor, well-differentiated epithelial neoplasm arranged in cords or nests, trabeculae or small nested forms with neuroendocrine cells that have abundant granular pale acidophilic cytoplasm and kind of a relatively monotonous nuclei that have a salt and pepper nucleochromatin distribution. As in other anatomic sites, grade 1, 2, and 3 are kind of separated out based on the numbers of mitotic figures. So grade 1 net is really anything that lacks necrosis and has less than 2 mitoses per 2 square millimeters, while a grade 2 net may have some necrosis and 2 to 10 mitoses. And then that optimal Ki67 index for those that are grade 3 has not yet really been well defined for the head and neck, although we are anticipating that that will be the case and therefore should be something that will be present. So as you would expect, they are going to have reactivity for epithelial markers such as CK-pan or CAM 5.2, even CK7, and then a variety of different neuroendocrine markers with synaptophysin and chromogranin A most sensitively, while the transcription factors such as INSM1 will be positive in these tumors as well. A variety of other markers can be seen, like serotonin and calcitonin, even TTF1. The neuroendocrine tumor category has an intact P53 and RB, which is often lost when you get into the neuroendocrine carcinoma category, and so these are very helpful. So here you will notice a low-grade lesion, very rosetted in its overall formation, small, almost Zellballen type architecture for a grade 1 neuroendocrine tumor that lacks any mitotic activity. Slightly increased degree of pleomorphism seen here in a grade 2 net, where there is an increase in mitotic activity as well, a slight increase in the nuclear to cytoplasmic ratio. Even more prominent nucleoli can be seen in this example of a grade 2 neuroendocrine tumor. Tumor necrosis is quite frequently identified in these lesions as well, as you will notice in the center of this field. Here you will see areas of apoptotic change as well as areas of necrosis in an example of a grade 2 neoplasm. There are just way too many mitotic figures in this case, with tumor necrosis and an overall increase in the nuclear to cytoplasmic ratio of a grade 3 neuroendocrine tumor. And here is another example of a grade 3 where you can see that there are 4 mitotic figures in less than a single high power field in this example. As I've already suggested, CK-pan may be diffusely and strongly positive in these lesions, with either chromogranin or synaptophysin diffusely expressed. Calcitonin can be seen in some of these neuroendocrine tumors, as well as TTF1 aberrantly expressed. Here is an example of an intact RB, which means that this tumor would not be classified in the neuroendocrine carcinoma category, as this is one of the defining features between the lesions. So let's talk about small cell neuroendocrine carcinoma for a moment, having scant cytoplasm, finely granular chromatin, inconspicuous nucleoli, and usually a very high mitotic index. So most of these do occur in the larynx, although the sinonasal tract can also be seen, and recognize that, again, there is a strong association with tobacco use in the larynx, while oropharyngeal tumors can have high-risk HPV associated with them. So the neuroendocrine features must be seen and be predominant histologically. You can't just have a poorly differentiated neoplasm and only have neuroendocrine marker immunoreactivity and not neuroendocrine histology. So both features must be seen concurrently. The small cell neuroendocrine carcinoma cells are smaller than the diameter of 3 lymphocytes, scant cytoplasm, large hyperchromatic nuclei, very, very inconspicuous to absent nucleoli, nuclear molding, greatly increased mitotic figures with crush artifact usually easily identified, and of course it is possible to have a concurrent neoplasm present. So when I look at this, you will see that it has the same features as you would see of a small cell carcinoma in any anatomic site, with a very high NC ratio and nuclear molding, a very salt and pepper nuclear chromatin distribution. Crush artifact is easily identified throughout. And here you can see very small nucleoli, although they can still be identified in some of these cells. As I've already suggested, a very broad spectrum of both epithelial and neuroendocrine markers may be seen, but in this instance, there is global loss of RB. Well, as I said, the Ki-67 grading has not yet been applied, and yet we do think that anything greater than 20%, at least so far, seems to be an appropriate cutoff. So a strong pan-cytokeratin, synaptophysin, even INSM1, whichever one of these markers you can see, they are all very strong and diffuse. TTF1 can be seen aberrantly expressed in several of these tumors as well, and this is an example of a loss of RB. So you can tell that there is constitutive expression in the endothelial cells while the rest of the background has been completely lost. High Ki-67, and clearly this is not something that would be put into a lower grade neuroendocrine tumor, since this is clearly much more than the 20% cutoff. Sometimes the HPV-associated tumors will have an in situ hybridization technique for high-risk HPV, as you can see in this example, and in that case, it would be interpreted to be a positive finding rather than just relying on the P16 alone. Large cell neuroendocrine carcinoma, defined by cells that are much larger, vesicular chromatin and prominent nucleoli. Just be aware that IDH2 mutations have been seen in several of these lesions, but that SMARCA4 loss is part of the SWE/SNF complex deficient sinonasal carcinoma and should not be incorporated into the neuroendocrine carcinoma category at this time. As I've already suggested, loss of RB and P53 overexpression can certainly be seen in this tumor that has similar morphologic features, although now much larger tumor diameter and very prominent nucleolus present within the lesion. Here you can see a prominent nucleolus, lots of background sort of degenerated cytoplasm. Tumor necrosis is easy to identify within the central portions of the tumor. Again, tumor necrosis with this vesicular to open nucleochromatin and very prominent nucleoli present throughout. Positivity with CAM 5.2, INSM1, as you would expect to see in a neuroendocrine tumor. Finally, paragangliomas for this group are well-differentiated non-epithelial neoplasms. And of course, these are also seen within the head and neck space. They are quite commonly inherited. And again, the SDHD is one of the most commonly identified mutations in this group. The histology is that of a nested to Zellballen type appearance, and of course, a variety of neuroendocrine markers should be present with concurrent either S100, SOX10, or GFAP sustentacular immunoreactivity. We did ask that SDHB immunohistochemistry or some related equivalent be performed in most of these cases to be able to exclude the hereditary risk for these lesions. So here you can see bilateral tumors in an axial CT. Here is an example of a MRA where you can see this angiography nicely highlighting both of the tumors. And then, of course, one of the radionucleotide-based scans documenting several different tumors in this particular patient. Sometimes you will see radiographic instant material that has been used to embolize the tumors, specifically as they occur in the neck space. This is a common finding with a very characteristic Zellballen architecture for these tumor cells, highlighted very nicely with a sustentacular supporting framework with S100. Tyrosine hydroxylase can be used to highlight the cytoplasmic granules. And of course, the somatostatin receptors have also been documented to be positive in the cytoplasm of these neoplastic cells. GATA3 is usually seen in paraganglioma as well. And of course, a nice example here of SDHB loss, where the neoplastic cells are negative, but the internal control of the vascularity gives you a nice granular cytoplasmic appearance. So I hope that that particular overview sets you up for the rest of the presentations that will be coming in the next few minutes, and I appreciate your time.